The need never stops. Every day, people rely on blood donations to save their lives. But donations, as we know, took a drastic hit during the pandemic. Are we back where we need to be? We'll find out. Plus, today, we follow the blood from your arm to the hospital blood banks, all the way to critical patients in need. Good morning. It's Monday, January 9th. I'm Jessica Lovell. Welcome to the Morning Medical Update and to the Dulcie Simons Jr. Family Broadcast Studio. The organization America's Blood Centers found a blood transfusion is needed every 2 seconds in the U.S., but just 3% of the population donates blood each year. So you do the math. Get your questions sent in to us on YouTube, Facebook, and the Medical News Network. You can find links to all of those right there on your screen. Imagine the difference you can make by just rolling up your sleeve and donating blood. Giving blood is the easiest way to save up to 3 lives in just an hour. Joining us to talk more about this is Chelsea Smith with Community Blood Centers. Also along with us is transplant surgeon and VP of Perioperative and Procedural Services, Dr. Sean Coomer, and transfusion safety nurse specialist, Tori Tabery. She is going to take us behind the scenes here in just a moment, just kind of an area of the hospital you don't really get to see every day. How are you guys doing today?
Great.
Up and going on this Monday?
Absolutely.
All right. Good to see you. Chelsea, good to see you, because I want to start with you. Give us an idea of where the current supply stands here in our area.
Yeah, unfortunately, today we're sitting at about a 1 to 2 day supply across most blood types. That does include O-neg. That's the most commonly used blood type, especially in emergency settings when we don't have time to type a patient. So it's very low right now. We typically like to have a 7 to 10 day supply on hand at all times. So we're sitting at about a 1 day supply for our O types, 2 day supply for most others.
So it's Donor Awareness Month right now. So historically, winter is a slower time for donors due to holidays, weather, people traveling. So let's try to make it as easy as possible for people. Just come out of the gate, tell us where and how we can donate.
Yeah, the best place for you to find that information is going to be online at savealifenow.org. You can find all of our locations for blood donation, including community blood drives throughout the metro and 7 neighborhood donor centers. You can make appointments online, and you can look up some eligibility information there too to find out whether or not you're able to donate.
And we're going to put a QR code up on our screen right now. You can check it out throughout the program. You can scan it. It'll take you to donor locations here in the metro and a bunch more information that Chelsea just discussed. So walk us through, Chelsea, what happens after donating blood. What happens to your donation from the time you leave your appointment to when it then arrives to Tori here at the health system?
Yeah, great question. So right after you donate your blood, it's immediately packaged into these special coolers specific to human blood. We send it right there on the screen. We send it straight to our lab where it's tested for any evidence of infectious disease. And then after that, it's split into its components. So that includes red blood cells, plasma, and platelets. We split those units up. They're used to treat different patients for different ailments. Once that is gone through our components department and split up into its parts, we send it to distribution where they pack it into coolers again. And this time, those coolers are going to head out to hospitals where they will meet up with Tori and treat patients.
So, Tori, I'm going to let you take it from there. Walk us through how blood is processed and then distributed once it arrives to you guys.
Sure. Yeah, absolutely. As you can see in the video, it comes in a community blood center box. Our awesome blood bank staff unboxes it and scans it into the computer. After scanning it, they will do some confirmation testing to ensure that it is the type that they're expecting, and then put it in special storage and wait until it is needed at the patient's bedside. Once it's needed, they will pull it out of the storage container and do some more scanning to verify it's going to the correct patient, and then have some tags they add to it for patient identification and verification, and then pop it in the tube system and send it to the patient at the bedside.
It's like old-timey bank system teller, like when you used to do that. You remember?
Yeah, I do, yes.
All the way back in the day.
Not that long ago.
God, okay. That was cool. Okay, we always love to see behind the scenes, so thank you for taking us there. So how much blood does the health system prefer to have in storage? What makes makes you feel confident? And Dr. Hoover, I'm going to ask you what makes you feel confident.
Sure. So I wasn't sure. I walk into blood bank and I see just kind of like rows of blood products, and it seems right to me. But I talked to some of the blood bank staff, and it turns out that we like to have 420 units of our various blood products to feel like we're at par and stocked for any need and patient need that may arrive.
So, Dr. Cooper, does blood just magically show up when you need it? Do you just these folks are always doing their job correctly, and all the way back down to Chelsea, so they're communicating, and then when you need it, it's right there. But is there communication between the two teams about where we stand? And so does that have to do with the scheduling that we can do with certain types of procedures and whatnot?
So by and large, our blood bank is right on top of it, right? So there's sort of this, there's this trust that we have as physicians that it's there. We usually get contacted if there are problems. But nonetheless, when there are bigger procedures where we know there's been blood loss, we usually have communication to the blood bank, and then they come back to us and say there's a problem, or we have low stores. But we do some communication hospital-wide when we do have less blood available.
So how did you feel the hit during COVID? What was that? Or were we able to kind of, even though it was a lot of work to keep up with that demand, were you able to, what did you see? What did you sense?
Yeah, during COVID, I mean, there was a double-edged sword there, right? So number one, yes, blood was down, but we're using a little bit less blood because we did less surgery and less invasive procedures. Nonetheless, we did feel that, and it was kind of an unknown shortage. We had a lot of unknown shortages in COVID, whether it be, gases to function all of our tools and robots and so forth, and blood was one of them. And so we didn't feel it as badly, but it was definitely an issue we needed to be aware of.
So Tori, how were you all impacted? What were those conversations like day to day during COVID?
Sure, yes. So, well, I wasn't in the role at this time. I know that there was basically just a lot of communication between the community blood center and the blood bank, and then those frontline providers. Our blood bank does an excellent job of communicating with the nurse and the provider if it's going to take a little bit longer to get the patient the blood that they need, but truly that key communication helps the process run smoothly.
That's the video I wanted to see. I want to see again some of your team, if we can go back and show that video of what you're doing, because I want to know exactly what your team does, how many people are up there working, kind of shine the light on how this all works.
Sure. So I am a transfusion safety nursing specialist, and my role is truly a liaison between blood bank and nursing. My background is in nursing, but in this role I work really closely with our blood bank staff and blood bank leadership to ensure patients are able to get the blood that they need. I often answer nursing questions, help ensure safe blood administration at the bedside, and support blood bank and help them kind of understand what's happening at the bedside, but then also help nurses understand what's happening in the blood bank. So in this video, you'll see our blood bank kind of has two specific parts. There's the front bench where they answer phone calls, they do a lot of the issuing and receiving of blood products, they keep things organized, their orders come through on the printer, they tag up the units, they send them through the tube system. In the back of the blood bank is actually where the testing occurs. So when you are a patient, maybe in need of blood, we will actually get a blood type on you, and they actually hand test those blood types to ensure that we know the correct blood that you need.
So Chelsea, I want to ask you, I know your answer is we need all types, but is there any type of blood that you need more of, or do you contact people who have a certain type of blood type that you need to come out? So tell us kind of what the status is on the different types and how we can help.
Yeah, you're right. We do need all blood types, but specifically our O types are most commonly used. So O neg and O pos today are sitting at about a 1-day supply, which, as I mentioned, is incredibly low. They are the most commonly used blood types by far. However, we also need A neg, B neg. Usually our ABs, we prefer them to donate plasma because AB plasma is the universal plasma type. So we need a lot of AB plasma as well, but specifically our O's have been consistently low throughout the pandemic. O neg, when it gets this low, it's very concerning. There's a lot of red flags being thrown up on our end here, trying to get donors in the door. We also, once you've donated with us, we know your blood type. We'll let you know what your blood type is, and we communicate with you based on what your blood type is. We let you know, hey, we need additional A neg. That happened just last week. We were running exceptionally low on A neg. We put out a social media post. We sent out communications to our A neg donors, trying to get them in the door. So our donors who have donated with us regularly are aware that we communicate to them like that, especially with those O neg donors. So you're probably going to be receiving communication from us today if you're an O neg donor trying to get you in the door.
Dr. Cooper, how common are transfusions? How often do people need them, and why would they need them during a particular procedure?
During procedures or operations, it occasionally happens. It's not all the time. Actually, most surgeries and procedures go without any transfusion whatsoever. But sometimes there's those unknown things that happen in surgery, whether it's a more invasive tumor that they have to take out, or they're taking out some blood vessels and things of that nature where it's required. And then you think about traumas. It's obviously in backup, but they don't necessarily like to always use a ton of it unless they have to. Other things that people get, anemia of chronic disease, they might need it in the operating room or other places. A lot of people get blood transfusions that might be on chemotherapy. So they are obviously being bombarded with their chemotherapy, and they have low blood levels, so they will get blood as well routinely.
You mentioned trauma. We're a level 1 trauma center, as we know, but kind of put it into perspective, when we go low or when those conversations start happening, or people aren't donating the way that we like them to, kind of how does that impact patients, or what kind of stress does that put on our trauma centers?
It's unbelievably stressful, right? So those are not elective procedures. They show up when they show up, and it's always a 5-alarm fire in a lot of ways. And we try to keep it from being that, but there's all these unknowns, and how much blood they need, and what their injuries are, and what their ongoing need will be for blood. So those are difficult things to predict, and difficult things for a blood bank to deal with, and as well as a community blood center.
So Tori, I want to ask you, people can reject blood products if for religious reasons, let's say, for one example. How do you help guide patients through that? And I know you both kind of have a perspective of that. Are there other options other than blood?
Truly, no. We have things we can do in anticipation, such as starting iron or other things prescribed by your doctor, but truly there is no substitute for a unit of red blood cells, platelets, or plasma.
Yeah, what do you do in those cases? Are those conversations you have to have pre-operation? Is that a typical question?
Yeah, a lot of this has been driven by religious organizations, and it has to do with preparation and technique a little bit. And so what I mean by that, as was mentioned, iron infusions, you can use something called erythropoietin, which is usually normally made by the kidneys to stimulate the bone marrow to make more red blood cells. But that can be used exogenously as well, but that doesn't happen overnight. That won't work for a trauma, for instance, or an emergency. That has to happen over a month-long period of time to kind of stimulate that. Some people can sometimes donate their own blood for storage. Does not work nearly as well. It doesn't work that great. And there are things we do in the operating room. We can sort of auto-transfuse. So we have something called Cell Saver. So there's different preparations. There are different sizes we call bowls in there. And for a small volume, you can actually use a smaller bowl, and as a result, you can recirculate and repurpose that blood back to the patient as well in the operating room.
But a good old-fashioned blood transfusion works best in most cases where...
Yeah, the best honestly is fresh blood, because when you have blood that's been sitting on a shelf, it loses something called 2,3 DBG, and it doesn't work as well, if you will. It doesn't load and unload oxygen nearly as well as fresh blood, but nonetheless, blood is definitely
irreplaceable in some ways.
Absolutely.
Let's talk about bloodless medicine. What is that?
Yeah, that's sort of what we're talking about right here is preparation technique to try to prevent having any blood transfusion. And that things like EPO and things like, iron and things, but nothing's perfect except your own blood, really. And you really, in technique, right? It's very important. So when I think about transplant, liver transplantation has long been considered some situation where you have a lot of blood. It's sort of an elective trauma, if you will. But here we're pretty careful. I can tell you 55% of our liver transplant patients don't receive any blood products. Another 10% only get 2 units of red blood cells. So that's actually a really good number. So we try to limit that the best we can.
Tori, jump in on that as well.
Yeah, no, that is truly incredible how I feel like our hospital does an incredible job of being great blood stewards and certainly transfusing when necessary, but also doing a lot of mitigation and excellent surgical techniques to prevent that need for blood.
Let's take a quick second, check in with Dr. Dana Hawkinson, Medical Director of Infection Prevention and Control on this Monday. Good morning, how are you?
Good. It's a good Monday.
It is.
Yeah, so right now we have 70 total patients in the hospital. Of those, though, 44 are active. Unfortunately, we do have 10 in the ICU, and 6 of those on the ventilator. So we do have some severe illness here right now in the health system.
All right, Doc Hawk, the World Health Organization says the new COVID strain is the most transmissible yet. Should we get back to full masking? What kind of concerns does this bring top of mind for you?
Yeah, and again, I think we discussed this a little bit last week. You know, it just seems like every new variant we see is more transmissible. You know, just jokingly, it's like even if we say it, we get it now, we get the infection. But, you know, really what they are talking about by more transmissible at this point in time is really that evasion of antibodies. We know there are other parts of our immune system that help protect us against disease and severe disease. We're also looking at the virus for other growth advantages. But should we be masking? Again, since very early on in this pandemic now, and for quite some time, it has really been down to that individual understanding their risks. And I think certainly people understand, what is my risk of getting severe disease and going to the hospital? The first thing we should be doing is, of course, being up to date with our boosters. Next, if we are talking about those non-pharmaceutical interventions, those public health interventions, masking is always going to be okay. Understanding what kind of situation you're in, especially if you are in a closed space with poor ventilation. Traveling, I would certainly really strongly encourage people to mask when they're traveling, more for the reason if you really don't want to be sick once you get to your destination, but also if you're going home to visit family or somebody who may be otherwise at risk, you want to make sure you're not going to get it and give it to them. So certainly masking is always appropriate and could help reduce your risk of infection, but also spreading it to others.
Okay, yesterday I took my kids to one of those like jump park trampoline indoor where they were mixing and mingling with all sorts of kids. I said, wash your hands, don't put your hands in your mouth. Didn't go so well. So new study found that children exhale significantly fewer potential infectious particles than adults. So what does that mean for my kids yesterday? Are they getting more potential for getting sick?
I mean, again, this is more of a translational or basic science. You know, they were just looking at it. Number one, it was a very small number of patients. They were looking at different age groups, so that breaks the actual ages down to even smaller numbers. They just found that those younger kids expressed less of those lower respiratory tract, smaller respiratory droplets out. What does that mean clinically? I mean, it's hard to tell, just because you understand, as you just said, you know, kids are just so good at spreading diseases amongst themselves. And then, of course, what we have seen throughout this winter, especially when we're talking about RSV and influenza, is bringing it home to their families as well. So, you know, I think it's good knowledge. I think we still need to work on that, but we understand that children are quite good vectors at spreading any and all diseases. So it is vitally important, just as you said, make sure you're working with them to understand good hand hygiene, doing it prior to going into a place or a party, doing it before they're leaving, and doing it frequently throughout the day is one of the other little things that you can do to help prevent further spread of diseases.
Yeah, it was pretty gross.
Yeah,
You're not judging me, are you?
No, they are. Just wash your hands. And I think if you're washing your hands, you are going to cut down on 90% or more of those diseases that are spread, especially amongst those little kids.
Oh, and I threw them in the shower when I got home, too. So just in case, hopefully that helps. All right. Do we have any reporter questions on the line today? We do not, so let's get to some great community questions from our viewers. Carrie wants to know, what is the most common use for donated blood? I know you kind of talked about that, but what would be most common use? You know, in a hospital.
Yeah, I mean, I think some of the things we mentioned, right? Traumas, some surgery situations, and I know every week, every day, there's folks getting transfusions, even not in an emergent manner, right? So they're having chemotherapy and their blood levels are low. And I think that's even more common, to be quite honest, but I don't have the exact numbers.
Yeah.
Any thoughts, Tori?
Oh,
okay.
No.
All right. So, all right, Joellen, I do love you. You watch all the time. She says the phrase, and I did use it during COVID, implies that it's over. Curious what you think about when we use that, because we do use that term a lot during COVID, as if it's in the past. We know it's still with us. It's going to be with us for a while. She's curious if there's a better phrase we could use. I will work on that. But what are your thoughts when we kind of live now with this kind of past and now present of COVID, non-COVID?
Yeah, I think, you know, when I think about during COVID, COVID. So I always tell folks, I never worked harder in my career than when we did in the first,
height.
the height of COVID in the 2020, 2021, and that had more to do with what are we doing to react to it, and how are we making our patients safe, how are we making our health system safe. And that consisted initially of shutting down surgeries and getting PPE, in the correct situation, keeping our employees safe and our patients safe. So when I think about during COVID, I agree it's a bad term because it is still going on. I think about the peak of where we didn't know exactly what the next day would look like.
And we didn't have a vaccine.
We didn't have a vaccine. We had a lot of things that we just didn't know what was going to happen next, and that's sometimes true today. So I think about that emergency and anxiety time period. Now I think we know a lot more. It doesn't mean it's over, but it's certainly a better situation. We're better prepared.
Doc Hawk, can we think of a better thought or a better way of saying during COVID? But I think I totally get what you mean, Joellen, for sure. But I do think we mean that height when there were so many unknowns, right?
I think that's probably in most people's minds, the height, especially when there were restrictions, lockdowns, there were masking, there were capacity restrictions, things like that. We can define the pandemic in so many ways, and of course our experience here in the United States is much different than a lot of other countries as well. I think the best way that I heard to describe it is when it was impacting our daily life on a regular basis, which it seems to be doing less now. And I think those, for reasons especially that Dr. Coomer mentioned.
Yeah, the height of COVID maybe would be a good way of saying it. I got a little praise for Dr. Coomer from Heather this morning, one of your patients. She said, "Good morning, Dr. Coomer. I'm enjoying life after my kidney donation to a dear friend." So you took it out. Yes. And handed it to Dr. Schmidt to put to her friend. She said, "You're amazing. God bless. Great seeing you this morning."
Good to see you too. Thanks. I hope you're doing real well.
I had to give a little shout out to all that hard work you're doing. Ann wants to know, Chelsea, she said one time when she donated blood, they didn't get a full unit. They told me that my donation would be discarded. I don't know if she had it at Community Blood Bank, but she said it kind of soured me, she said, on trying again. Is less than a full unit thrown away typically?
Yeah, unfortunately, that's part of the regulations that we're required to follow per the FDA. So it's our goal to always get to, I can't remember the exact milliliter measurement, but we have to get to a certain amount in that unit or we have to discard it per FDA regulation. Unfortunately, sometimes people clot, sometimes donors might come in less hydrated, or maybe something malfunctioned with the blood bag and the blood wasn't pooling like it normally does. That happens very infrequently, but sometimes it does. And, to the individual who wrote that, I'm sorry that happened to you. I will say that's pretty rare. It's not something that happens very often, and we do everything in our power to avoid having to discard blood at all costs.
Of course, but you're also following FDA guidelines, and we certainly appreciate that. And I don't think a lot of people knew that you have to have that full unit. And again, that it doesn't happen often, but when it does, that's just the way it goes. Brian wants to know, what's the difference between a blood or platelet donation or plasma donation?
Yeah, that's a great question. So when we're talking about whole blood, that's what people typically think of when they think of a blood donation. We're just taking a pint of your blood in all its glory. We're taking it to our lab afterward and splitting it into its parts. Now, platelet donations are different because we use an automated process called apheresis. So you come in, we hook you up to a needle, and essentially for the next couple of hours, we are taking out small bits of your blood, putting it into a centrifuge, and actually splitting it into its parts there on site. So we're able to keep either your plasma or your platelets, whichever donation we're collecting from you that day, and we return your red blood cells to you with a saline solution. So it's a lot of people actually feel a little more hydrated after a platelet or plasma donation, but those donations are beneficial because we're able to keep just what we need the most from your blood unit and give you back the parts that we don't need that day.
Terry wants to know, does blood go bad? When does it go bad? How long can it sit on the shelf? And that's a question for you, Chelsea, and then I want to ask you, Tori, as well. Chelsea, you first.
Yeah, unfortunately, it does go bad, and that's a huge reason why we're in a blood shortage. We can't stockpile blood and hang on to it for a rainy day. Red blood cells expire after 42 days on the shelf. Platelets expire about 5 days on the shelf, and I believe plasma can be stored and frozen for up to a year. So these are all perishable products. They aren't going to last, forever on a shelf. And if they do expire, which is not happening right now because we don't have a whole lot of blood coming in the door, but if it does expire, then unfortunately those units would have to be discarded, only because they're no longer viable to be transfused into a patient.
So, Tori, they must expire on your watch then.
Yes, our blood bank does an excellent job of getting nearly expired units where they need to go. They keep close eye on units when they expire, and will ensure they're transfused before that expiration date.
All right, we are going to wrap up and get some final thoughts. And Tori, I'm going to start with you. Is there anything about your department that I haven't asked you about? Anything cool that we need to know about what you all do up there? And thank you for kind of showing us behind the scenes. I love that.
Yes, absolutely. No, I am so thankful for the opportunity to work with our blood bank. They do an excellent job providing safe blood products for all patients of our health system. And I'm thankful to our blood donors. They truly are saving lives and keeping our patients healthy.
Dr. Cooper, final thoughts from you.
Yeah, I mean, I obviously can't practice medicine without donation. That's organs, that's, obviously blood as well. So we count on our fellow man to help us in that. And so it's really important, when we get in these crises, we'd like to prevent having these crises, right? Mm-hmm. So, constantly renewing your vow to donate blood is paramount. When you get those notifications in the mail, just to remind you, I think it's really important. And I'll ask Chelsea, I'll go off script here, but how often can someone donate? I think that's really important for folks to know.
Yeah, that's a great question as well. So for whole blood donations, you can donate every 8 weeks, so about 6 times per year. For platelets, you can donate every 7 days, actually. So that's up to 24 times per year, but we need a lot of platelet donations. Those expire real quickly, like I mentioned. And plasma donors can donate once a month. So this is definitely a habit that we encourage donors in our community to build. Keep donating and then coming back, making your appointments to come back throughout the remainder of the year as well.
Such an easy way to get back. And that's why I wanted to do this program, because it really shows the donor that it starts with them and that it ends with you and your patient, really the patient at the end, being able to be healthy and go through those surgeries and procedures and traumas. So Chelsea, anything else that you want to add? Just a reminder, again, we have the QR code up on the screen, different locations where you can donate blood here in our community. Just any last final thoughts that we should know about?
Yeah, so last week we actually did launch a campaign called Give Life KC. We're partnering with our hospitals, we're partnering with community leaders to address this problem that it really is a community problem. A blood shortage impacts everybody, and unfortunately it's a national blood shortage too. So we're not the only region in the country dealing with this. The only way out is blood donors. So we need people to come in, we need people to hear this message and shoulder this burden with us, partner with our hospitals by saving lives through blood donation. You can go online, like I mentioned, to savealifenow.org and find all of our donation locations listed there. You can search for your zip code to find the locations nearest you, and you can go ahead and make your appointments for the rest of the year if you want. We would love that. We welcome that. So I would just say truly, as we discussed, there is no true substitute for human blood. And the only way we're able to obtain that is with blood donors coming in the door and donating that blood.
And as we said up the top of the show, 1 hour, and it makes this huge impact across the board. So, Chelsea, thank you for all your outreach and all the work you do in our community. Thank you so much. Dr. Hawkinson, final thoughts today?
Yeah, I think we'll just kind of play off one of the questions and just, again, understanding your risk, be up to date with your vaccines. Again, not just the COVID-19 boosters, but all of those vaccines to help prevent those diseases that are prevented by these very safe, very efficacious vaccines. And again, just as you said, Jessica, continue to wash your hands on a regular basis.
All right, good advice. Everyone, thank you so much for being with us today. You can catch our updates anytime by logging back onto Facebook, YouTube, and Twitter. Go out, make it a great Monday, and we'll see you back here tomorrow for an encore presentation. And then Wednesday, we're back for a live open mics with Dr. Stites. We're going to show you a new way to treat brain tumors that doesn't involve radiation every day for 6 weeks. We'll see you then.
Subscribe to our morning medical update and open mics with Dr. Stites podcasts. Now, everywhere podcasts are available.